everybody, my name is Dr. Danielle Carter. I am a GP and I am also of Aboriginal descent. I come from the Gurangaran tribe in the wider central Queensland area. Today we're going to do a case study focusing on Chapter 5 of the National Guidelines, which is Preconception and Pregnancy Care. So we've got Sarah today. She's a 22-year-old Aboriginal female who lives in her community about 100 kilometres west of Alice Springs. Sarah usually attends the local Aboriginal Community Controlled Health Organisation, or NACCHO for short, for healthcare and social activities such as attending the women's space. The NACCHO does not have consistent access to a regular GP or locum service. However, they do have an Aboriginal health practitioner available. Sarah does not have access to her own transport and relies on health service providers and family to travel to and from appointments outside of her community. Sarah has asked her auntie to bring her to Alice Springs to attend the local GP clinic today. Before even starting the consult, what are a few things a health practitioner should be mindful of? So we actually need to consider if this is a safe place for Sarah to be. So the practice needs to be culturally appropriate. So there are a few easy things you can do in your practice to ensure that it's a safe place for Aboriginal and or Torres Strait Islander patients. So some simple things you can do in the practice waiting room and in the consult rooms is Aboriginal artwork, flags or signs, welcoming First Nations patients and their families. It's essential that all staff members have cultural awareness training, and I think this is really appropriate for reception as well, as they're forward facing and they're the first people that a patient may see when they come into the practice. It's also important to identify which patients of yours are Aboriginal and or Torres Strait Islander so you can offer them culturally appropriate services, and there may be some special resources that they are eligible for. When we're looking at Sarah's consult today, we want to know if the doctor is the right choice for Sarah. So that might be a male or a female doctor, or we need to take into some cultural considerations about tribal lines. Sarah might also be offered the involvement of an Aboriginal health practitioner during her health consult today. Sarah may also want language or translator services. And then we also might want to extend, just going to go back a minute, sorry. Sarah may also want a family member such as auntie or another family member included in the consult to make her feel more comfortable. Telehealth might be an option if she wanted somebody that wasn't, sorry, I'm going to pause there and go back to that. We also need to consider whether Sarah wants another family member or her auntie in the consult with her. If they're not in Alice Springs today, telehealth may be an option. So I'm assuming all of you guys have already done this in your clinic. So Sarah walks in to find the clinic has Aboriginal artwork displayed and a sign welcoming First Nations patients. She has previously advised the reception staff that she is Aboriginal, and this has been recorded correctly in her patient chart. Sarah has been booked in with a female today, which she is most comfortable with, as this is a sensitive issue. Usually Sarah does not mind whether the doctor is male or female, however. The front desk staff offer the inclusion of the Aboriginal health practitioner for the consult. Sarah advises yes, this would make her feel more comfortable. Sarah declines a translator as English is her first language, though she can speak bits and pieces of her Aboriginal language. Sarah asks if her auntie can wait outside during her consult. So we're going to move into the consult area now. So during the consult, Sarah advises that she's been feeling unwell for the last few months. So her symptoms include tiredness, a bloating sensation and what feels like a lot of gas moving in her stomach, constipation, and she did have some minor nausea a few months ago, but this is now resolved. Sarah wonders whether her iron might be low because her auntie has had that in the past and her blood tests showed a low iron. So we need to pause here and have a think about our differential diagnoses. And clearly, because we're doing preconception and pregnancy care, that's going to be our number one diagnosis. So the further questions and answers provided are, Sarah had her last period 4 months ago. It was very light, however, and it was just a few spots. Usually Usually Sarah's periods are regular, occurring every 28 to 30 days, and they last about 3 to 5 days. Sarah advises the bleeding's not overly heavy. She's been in a relationship with a male who lives in her community called John for the last 2 years. She advises her mental health is stable. She has had a bit of anxiety in the past, especially during high school, but there's no concerns right now. She smokes about 15 cigarettes per day, as does John. She drinks a few glasses of wine every weekend. Sarah does not engage in illicit drug use, and there's no past medical history or regular medication use. So I guess the other questions that we need to think about are related to women's health and reproduction. So at this stage, I would be asking a little bit more about her reproduction history. So has Sarah ever been pregnant, and what are the outcomes of any pregnancies that she's had? Was Sarah using contraception recently in the last 6 to 12 months? What are her pregnancy intentions? Does she want to get pregnant now or in the next 12 months? And I'd also like to explore the relationship with John. So what's the relationship like? Is there any cultural issues? Is there domestic violence? Is he a safe support for her? We also then want to explore those risky behaviours there, which are the smoking and the alcohol. So I'd like to explore her readiness to quit smoking and reduce alcohol at this stage. So we do a focused examination while Sarah's in the room with us. Her blood pressure is 128 on 85, pulse is 95 beats per minute, heart sounds dual with no added sounds, chest clear, and the thyroid examination was normal. Abdomen was soft, but you could palpate what you thought was the uterus above the umbilicus, and her urine pregnancy test is positive. You advise Sarah of the result and tell her a scan is needed to see how far along she is. Luckily, you're co-located next to a radiology clinic who has a spare appointment right now and can fit Sarah in for an urgent scan. The Aboriginal health practitioner accompanies her for a pelvic ultrasound. The result of this ultrasound comes back as a single live intrauterine pregnancy, and the growth shows a gestation of 22 weeks. Now, the radiologist didn't have time to do a morphology scan today, but is able to provide the information that she is 22 weeks pregnant. So Sarah comes back to the clinic after lunch to discuss the scan. The radiographer showed her the images of a baby, but didn't actually provide her any further information about the pregnancy or how far along she is. Now, this is going to be a bit of a tricky one. So how are you going to tell Sarah she's 22 weeks pregnant? So what we want to do is a person-centered approach, and we can incorporate the family and cultural roles if needed and desired by Sarah. We want it to be strength-based and responsive to the needs of the patient. We want to make space and time for family or support people to attend appointments, either in person or remotely, to discuss results. And at this stage, we could consider including John in the conversation via a telehealth platform. We want to establish a safe space for clarifications and questions, and the doctor should ensure that Sarah understands what is being communicated. We can also consider using Aboriginal and Torres Strait Islander people's co-designed and tailored resources to aid in the communication if needed. We're obviously going to invite the Aboriginal health practitioner to be a part of the conversation if Sarah desires that. And we're also going to ensure that follow-up or further time is allocated to provide further counselling to Sarah in the near future if required. Now, if she needs to go back to her community today, you can obviously do that via telehealth. So, we have a 22-week pregnant young female who has had no antenatal care to this date, and a few other things going on in the background as well. So I feel overwhelmed right now. There's quite a lot to do, and this may need to be split over multiple appointments, and it might be worth doing telehealth to check for her understanding and ensure that follow-ups are... Sorry, I'm going to start that again. Why is that doing that? Okay, so what next? So I'm feeling a little bit overwhelmed right now. We've got a young female with an unexpected pregnancy who's 22 weeks gestation, and she hasn't had any care to date. So what needs to be done is obviously going to be split over several appointments. And I think we're going to have to carve out some extra time to make sure Sarah understands and that appropriate investigations and follow-up are being conducted on the right time. So what we need to start with is actually ask about Sarah's pregnancy intentions. So does Sarah actually want to be pregnant? Does she want to have this baby? Is she safe and supported to have a child? Will John and other family members and the wider community be accepting of this pregnancy? So this is where we just need to pause and consider the effects of the stolen generation. So we want to know, is Sarah worried that she could be parted with her child, and whether this has happened in her family in the past? So that's just one of those special considerations we need to extend to Aboriginal and or Torres Strait Islander peoples. Now, let's assume that Sarah, although unexpected and a bit shocking, does want to go ahead with this pregnancy. So we need to pop her on the appropriate multivitamins, and you can go and look up the appropriate multivitamins in the national guidelines. We also need to discuss smoking and the risks in pregnancy, and we need to support smoking cessation ASAP. Same goes for alcohol, so discuss the risks of alcohol intake during pregnancy, and we need to support cessation of alcohol immediately. We also need to discuss nutrition, healthy weight gain during pregnancy, and exercise. Immunisations as well. So given that she's already 22 weeks pregnant, if the flu vaccination is currently in stock and we're in that season, I'd be providing that today. The DTP, which is the whooping cough vaccine, and the RSV, which is respiratory syncytial virus vaccine, can be done after 28 weeks. And then we're going to review the mental health. So we want to explore the home situation, relationships, and childhood experiences. Now, as first-line investigations, we need to organise a proper morphology scan to have a look at the baby. We need to do some blood tests. So the things that I'd be looking at doing would be hepatitis B, hepatitis C, HIV, syphilis, rubella, blood group, and antibodies. Urine test. So I'd be looking at a urine MCS and a first void for chlamydia and gonorrhea. And just a quick note there that the chlamydia and gonorrhea testing can be done via other ways such as a throat swab, anal swab, or an endocervical swab if required. We also need to consider the need for a full blood count, iron studies, fasting glucose, and kidney and liver function, just because Sarah may not have had these done in the past 12 months, and we want to assess for any underlying concerns that may affect her pregnancy. Now, it's important to note here that it is too late to consider genetic and chromosomal screening. We would be looking more at the morphology scan to see if there's any concerns there. And obviously, if there is any issues, we would refer to a tertiary centre. Now, Sarah's been fantastic. All the recommendations are implemented. Her investigations all return normal. So Sarah's now moved back onto her country, and a telehealth appointment is utilised to convey all the lovely news. Now, Sarah's still got 18 weeks of pregnancy to go, and we need to consider who's actually going to provide her antenatal care. Can it be done on the community with the Aboriginal health practitioner, or does she need to come to Alice Springs? When will the appointments be scheduled? What can Sarah expect for further testing? Where will Sarah deliver her child? And what happens if a complication arises? So just discussing all of these issues with Sarah and having a clear outline of the plan can be very beneficial for Sarah, and understanding where and who to go to if there is a concern. Now that brings us to the end of the case, but I'd like to just highlight some further considerations that we need to think about in delivering antenatal care to Aboriginal and or Torres Strait Islander peoples. Now, the first one I want to raise is avoid making assumptions. Aboriginal and Torres Strait Islander culture and peoples are very different geographically, culturally. There's a lot of things going on. So if you're not sure, don't assume, just ask. Most of us are willing to have a good yarn about it. You can also use targeted resources to help you provide culturally safe care. So obviously the national guidelines is a great one to start with. We've talked about providing Sarah with culturally and linguistically appropriate materials and services throughout her healthcare journey. And I think for everybody, we need to understand the referral process and the services available for Aboriginal and Torres Strait Islander peoples living in rural and remote communities. And I think you need to understand your local region and the referral processes that are available for you. We need to ensure Sarah is supported to access her appointments by working with Alice Springs Hospital Aboriginal Engagement Unit and the local ACCHO. Like I've already discussed, we need to establish clear pathways for follow-up and try and book appointments ahead of time. Providing support for transportation and accommodation for Sarah if she needs to travel to Alice Springs is vital to ensure that she attends her appointments. We need to consider and minimize, We need to consider and minimize the financial burden of antenatal care if required and able. We also need to think about what if a missed appointment happens. We don't want to go out with a negative attitude. If there is a missed appointment, what's the process? How do we ensure that we catch up appropriately? And then obviously once the beautiful baby's born, we need to link in with the ACCHO for healthcare, ensure they have pathways to health checks, dental care and immunisations. That's it for today. If you want to go further into preconception and pregnancy guidelines, obviously have a look at chapter 5 of the guideline. Thank you.